Today we're talking about genital lesions and ulcers. I think this is a very high yield video because some of these, they're really hard to differentiate from one another. And so obviously there's going to be a bunch of questions about them. Really the one you need to know about is just, a good old chancre. This is a painless lesion with a peripheral raised edge. Now, what they kind of contrast it to is a chancroid, which is painful, and we'll talk about that in a second. If you see the word buboes, which are just giant, painful, bacterially infected lymph nodes, kind of like the plague, that's going to be LGV. If you see the groove sign mentioned, that's also LGV. If you see anything about a beefy red lesion, and hopefully they throw in the Donovan bodies, this is going to be granuloma inguinale. And obviously, if you have a small vesicular rash on an erythematous base, that's herpes. But one thing they can do is they can leave out the word vesicular because it's too obvious, and they can call it an erythematous rash. The important thing to know is that these two, they're really not seen in the USA. So keep that in mind. If they mention an immigrant or you're on an international rotation on a boards exam, that would show up here. And so one thing you need to be able to do is contrast acuminatum and lata. And I put the picture of both, but what I want you to kind of hone in on is if they use the word cauliflower-like, you're thinking about HPV. And this is just treated with cryo. If they say that the growths are flat topped, this is secondary syphilis. One thing to keep in mind is there may or may not have been that initial chancre. Sometimes if it's, like inside, then it can be missed. Now, these are the Donovan bodies. They're little intracytoplasmic inclusions. And so what we'll talk about with herpes later is, if you remember that this is the nucleus, the inclusion bodies are outside of it. So they're intracytoplasmic. And so with really the buzzword is beefy red. And so you kind of look at those. And again, just emphasizing, because they really love doing this, is they'll give you a lesion, but then one of the reasons this will be a wrong answer choice is it's not commonly seen in America. And so if you have someone in America who hasn't traveled recently, their partner hasn't traveled recently, not an immigrant, then you really don't need to be thinking about this. This is what a chancre looks like. This is really this is going to be the answer like 9 out of 10 times is a chancre. And really the key is that it's painless. And so just integrating, if it was painful, that's chancroid. And one thing to know is the RPR and VDRL, these are called non-treponemal tests, and so they need to be follow up with a FTA-ABS, which is a treponemal test. And, because we always make everything complicated, this is basically just a blood sample, and it's just, tested via ELISA. Another thing to know is that rheumatoid arthritis, I think, is one of the things that can cause a false positive RPR. I saw this actually on my rural rotations, so they don't really test it too much, but in real life, you need to be aware of this, is that for some reason, syphilis, it has a scalp involvement that it kind of causes this patchy hair loss, especially in black women where it may be missed if they have braids. You really have to ask them and look for it. And so this moth-eaten appearance shows up in secondary syphilis. And it's really important to treat this because you don't want them to get tertiary syphilis. So I think the most helpful way is to just try to guess which one I'm talking about. And so I'll pause it for a little bit. A single painless ulcer at inoculation site with heaped up borders and clean base. Really the key here, I hope what you're doing is you're honing into that painless part. And so obviously this is a chancre, you're going to give penicillin. One more note here is that even if they're pregnant, you give penicillin. There's really no alternative to penicillin. Sometimes they can give doxycycline, but it just doesn't work as well. Multiple painful superficial ulcerations, and the buzzword here is erythematous base. So this is herpes. One thing to note here is they might give you the good old zinc smear, but really this is diagnosed on PCR, and the treatment is acyclovir. Deep, purulent, painful ulcers. So again, we're honing into painful versus painless. And you see suppurative lymphadenitis. That means the lymph nodes around it are kind of inflamed and oozing. And so this is going to be chancroid again. And this is caused by Haemophilus ducreyi and is treated with azithromycin. Painless, right? Again, this is going to be the key here to all of these. Progressive red serpiginous lesions. And they're ulcerative without lymphadenopathy. And so that's granuloma inguinale, which is donovanosis. And if they kind of almost, I feel like they almost have to give you, the Donovan body, or they have to describe them as beefy. So if we see gram-negative intracytoplasmic, right? So they're not in the nucleus, they're outside, cysts. So these are the Donovan bodies. Granulated cytoplasmic inclusion bodies. Inclusion bodies, it's a pretty good buzzword for chlamydia. And again, chlamydia is what causes the lymphogranuloma venereum, and you need to give doxy. One thing, if you kind of want to go above and beyond, is that this is the L1 to L3 serovars. And so, if we remember the D through K, that's what causes just like the, like USA chlamydia. So if we have a groove sign, and so I'll kind of point out what that is. So we have, the inguinal ligament here, and we have some femoral and we have some inguinal lymphadenopathy, and the ligament is splitting them. So this is almost pathognomonic for LGV, and you give doxy. Let's say you have someone with a very, I guess this could also be called beefy red, but it's really just the skin folds. And just to be nice here, we'll throw in, no new sexual partners and no discharge. And so the lesson here is, let's say someone's coming to you for a genital lesion, you have to know about non-infectious causes. And so this is inverse psoriasis. And really the key here is inverse psoriasis, you may or may not have the scale. And it targets the skin folds, not the extensor surfaces. That's why it's called inverse. And the key here is that 2/3 of people with psoriasis will have genital involvement at some point. And so, hopefully if it's a good question, they tell you there's also involvement of the armpits. This is kind of a summary of some of the things. So I want you to really, the treatment is, I would say, this is lower yield, but you really need to be able to describe them. And so if you only have time to memorize a few, no syphilis, no HPV, and no herpes, because that's what we see in America. The rest of these is more for completeness sake. And so this is what I was talking about earlier, how we're going to recognize herpes. So they're going to have these multinucleated giant cells, and these are called Cowdrey bodies. So they show up mostly in herpes, and they can also be seen in CMV, but CMV also has these owl eye inclusions. And so this is really a comparison. If you kind of imagine, this what an owl looks like. And another integration is that these are both intranuclear. And so if we had some intracytoplasmic, that's when we start talking about some of the other inclusion bodies. As you're studying these, you always need to think about how else it could be tested. And so one thing to leave with is it's most important to just focus on what's seen in America. So you need to be able to identify a chancre. You need to be identifying herpes lesions. And then also, I threw these in here because you need to be thinking about non-infectious causes. And so if you had something with a Bartholin cyst, they'll call it, like the posterior third of the vagina, posterolateral wall. This is typically going to be, a painful lesion. And you also need to be thinking about something like lichen sclerosis or psoriasis. So that's it. I hope this was really helpful for you. And if you get one thing from this, it would just be to